Can you see the?
Yes, perfect.
Okay.
Yes, perfectly.
Hello, everyone. Thank you very much for the invitation, and thank you, Dr. Sileli, for the organization. I am going to talk about the anterior cranial fossa and pituitary fossa anatomy. So, first of all, I would like to say the importance of the work in the laboratory could be with some different kind of course, or we can do a fellow, or we can have a laboratory in our hospital, but it is very important to study and to understand the anatomy in the laboratory. Why? Because we will win two things: the 3D anatomical knowledge of different parts of the skull, in this case the skull base, and also because the surgical praxis, because we imitate like the movements in the operating room. So first of all, we are going to talk about the anterior cranial fossa. And the anterior cranial fossa occupies the most anterior aspect of the skull base, and it is posteriorly delimited from the middle cranial fossa by laterally the sphenoidal ridge and medially by the sphenoidal limbus. And the anterior cranial fossa supports, of course, like we know, the basal frontal cortex and the olfactory bulbs. So this is the anterior cranial fossa, and lateral delimited from the middle cranial fossa by the sphenoidal ridge, and in the middle portion by the sphenoidal limbus. So the lateral part of the anterior cranial fossa is formed by the orbital plates of the frontal bone in the anterior 2/3 and the lesser wing of the sphenoid bone posteriorly. And in the medial part, we have the cribum plate anteriorly and the planum sphenoidale posteriorly. So we can see here the plates, the orbital plates anterior, and the lesser sphenoid wing posterior, laterally. And medially, we have the cribiform plate with the crista galli in the anterior portion, and in the posterior portion, we have the planum. Extracranially, the anterior cranial fossa is inferiorly related to, in the midline, the nasal cavity, and posteriorly the sphenoid sinus, and laterally to the orbit. So we can see the anterior cranial fossa, medially the nasal cavity, and posterior the sphenoid sinus, and laterally both orbits. So in relation with the nasal cavity, with the surgical view, because usually the neurosurgeons use the nasal cavity like a route to go to operate the anterior, the middle cranial fossa, and with the normal or standard approaches, and also with the extended approach. So usually we see at the beginning, this is in the right side, this is the septum and the middle turbinate and the inferior turbinate that usually we mobilize a little bit. And the portion of the turbinate that hidden the view is the middle turbinate that usually we mobilize a little bit laterally, but in sometimes we need to cut, especially with the extended approaches. So when we cut the middle turbinate, at the end we see this view. This is the ethmoid bulla, and in the posterior portion we have also the superior turbinate that sometimes hidden a little bit the ostium. This is the right ostium, this is the septum, and the superior turbinate, the posterior, the tail of the middle turbinate. One important thing here, below between the superior portion of the choana and the ostium, we have this artery that is very important in order to preserve when we perform the septum, the mucosa for the reconstruction of the surgery. This is the sphenopalatine artery that cross the sphenopalatine ostium between the orbit and sphenoidal process of the palatine bone. So from the pterygopalatine fossa to the nasal cavity. So we, in order to perform the nasoseptal flap, we have to cut below the ostium in order to perform and preserve the sphenopalatine artery. And we can see in this view, in a cadaver, ostium right side, ostium in the left side, a nasoseptal flap with the preservation of the artery in the right and also in the left side. In relation with the sphenoid sinus, this is an anterior view. Of course, we remove all the things we can see the anterior view or the anterior wall of the sphenoid sinus. This is left and right ostium. This is the optic canal, the superior fissure, the foramen rotundum, the foramen of the median nerve. So this is the anterior view. Sometimes it is common that the ostium in one side and the other side is not in the same level. This is the axial view of the sphenosinus. We can see this is the paraclival carotid artery. The septum that usually is not in the middle portion is sometimes to the right or to the left. And also it is important to see that the sphenoid sinus anterior it is bigger than posterior. This is the clivus, basilar artery, and the anterior recess of the sphenoid sinus. Another important thing is to understand the view of the sphenoid sinus from the superior view, from the endocranial view. This is the mucosa. We can see the projection of the sinus from an upper view. This is the pituitary gland that we cut at the middle. This supraclinoid carotid artery, optic nerve, and this is the cavernous carotid artery. And we can see sinus medially and also laterally, and also lateral from the V2 branch of the trigeminal nerve. So it is important to understand the 360-degree anatomy of the skull base, and especially of that part of the skull base, the pituitary fossa and the sphenoid sinus and so on. And we have to understand that if in one view some portion is concave, in the other side for instance, if for an intracranial view something is concave, in the exocranial view is convex, and vice versa. So for instance, this is an endocranial view and an exocranial view. This is the planum that is plane. So this is planum here. This is a view, an endonasal view of the sphenoid sinus. So this is the chiasmatic sulcus, and we can see here the chiasmatic prominence. Here we can see the tuberculum, and here we can see the tuberculum recess, convex, concave. Now we can see the sella, and we can see the sella prominence, concave, convex. Now here we can see the optic strut, and in the endonasal view, this is the optic nerve, this is the carotid artery, so the lateral optic carotid recess. And medially, at the level of the middle clinoid process, we can see here this, and here is relation with the medial carotid oculomotor optic carotid recess. Sorry. In relation with the orbit, we published this with the idea of Professor Roton some years ago about the rule of 7. Why? Because we have 7 bones in the orbit. We can see the bones, the maxillary, the lacrimal, ethmoid, palatine, sphenoidal, sphenoid, frontal, and zygomatic. Also, we have 7 muscles in the orbit, the 4 rectus, the superior and inferior oblique are 6, and the 7 is the levator palpebral muscle. So we can see in this dissection, this is the superior oblique muscle with the trochlea here. We can see the elevator and then the superior rectus muscle, lateral rectus muscle, here the medial rectus muscle, and in this dissection we can see also the superior oblique muscle with the trochlea, the levator, and then the superior rectus muscle, lateral, medial, and so on. And also we have 7 nerves. Why? Optic nerve, 1, the 3 that pass outside of the annulus of Sinn, the trochlear nerve, the frontal nerve, and the lacrimal nerve, and inside the annulus Sinn, more than the optic nerve, that is the first cranial nerve with the superior and inferior branch, and also the nasociliar nerve and the 6th cranial nerve. So in this dissection, we can see the 3 nerves that cross the superior orbital fissure outside of the annulus of Sinn, frontal nerve in the middle, lacrimal nerve laterally, and the trochlear nerve, 4th cranial nerve, medially. And inside, we can see the optic nerve. This is the lacrimal nerve. We can see the frontal nerve here. This is the nasociliar nerve. And this is the superior branch, this small branch of the 3rd cranial nerve. Let's go to the pituitary fossa, the second part of this lecture. And the pituitary fossa is related to the sella turcica. We can see here the beginning of the optic canal. This is the sphenoid limbus. This is the chiasmatic sulcus. This is the tubercle. And here we can see the middle clinoid process, anterior clinoid process, roof of the optic canal. This is the optic strut and the sella, posterior clinoid process, and this is clivus. So the pituitary fossa is where the pituitary gland sit, and it is related with dura mater that form the pituitary fossa. So this is the pituitary gland, and it is related to the cavernous sinus. So the lateral wall of the pituitary fossa is the medial wall of the cavernous sinus, like we can see in this picture. So here, in the right side, we can see a dissector, the pituitary stalk, diaphragma opening, and a dissector between the pituitary gland and a very thin wall of dura mater that is the lateral wall of the pituitary fossa and also the medial wall of the cavernous sinus. And here we open that lateral portion or lateral wall of the pituitary fossa, and we can see directly the pituitary gland. Another important thing is the anatomy of the diaphragm sellae. We published in 2008 this paper, but thinking about the growing of the pituitary adenomas. But we study and we see that in sometimes the opening of the diaphragm is almost just for the pituitary stalk. In sometimes the opening is medial in size, so we have some portion of superior part of the pituitary gland without diaphragm, and in sometimes, like in a empty cella syndrome, we don't have diaphragm, we have a very big opening, and usually the gland is flat in the inferior portion of the cella. So the situation could be like this, and like this. So we started to think about in the pituitary surgery, what can we have between the tumor and the CSF? And we have arachnoid. Sometimes we have dura mater, sometimes yes, sometimes not. It depends the size of the opening of the diaphragm, and sometimes we have pituitary gland. So we started to think this and published this in 2019, and we introduced this concept that is in relation with the pituitary surgery, the cellular barrier. We published in Pituitary 2 years ago this paper, and I would like to share with you this concept. We can see here a strong cellular barrier, but the diaphragm is just this, the dura mater. Okay, the other part is pituitary gland, not diaphragm. It's pituitary gland, not dura mater, because in the T2 we can see the pituitary, the difference between the dura mater and the gland, in the sagittal view, and we can see in the post-op that the gland forms almost the major part of that cellular barrier. Another example, we can see in this part something, a line with the enhanced, and here not. So here we have just arachnoid, this is a mixed cellular barrier. And here in the right side, we have pituitary gland. And we can see at the end of after the surgery that the gland is just in the right side, and in the left side is just arachnoid. Let's go to the cavernous sinus to finish this lecture. The cavernous sinus have an external structure, the dural envelope, superior wall, lateral wall, posterior wall, and medial wall, and also the internal content, venous blood, internal carotid artery, sixth cranial nerve, the sympathetic plexus, and also adipose tissue. But especially for the young neurosurgeon, it is important when we want to understand the cavernous sinus, we have to understand the dural walls of the cavernous sinus. So in relation with the superior wall, we have to remember that have 3 segments, oculomotor, clinoid, and carotid, continuous medially with the diaphragm that we already talked. And to fully expose the superior wall, we have to remove the anterior clinoid process. So the oculomotor portion is a triangle shape. We can see here. This is the first cranial nerve, the hole where the first cranial nerve go, and this is the anterior petroclinoid ligament, the posterior, and the interclinoid, the posterior and the anterior. And this is the oculomotor triangle. But it is interesting, in the lateral view, we can see the third cranial nerve and the fourth cranial nerve, that also the fourth cranial nerve introduced in the roof of the cavernous sinus for the most posterior and lateral portion of the oculomotor triangle. Another important thing, when cross over the hole in here, is not inside the cavernous sinus. The third cranial nerve has a cistern. It is between 1 centimeter and then start to cross actually the cavernous sinus. So we can see here the first cranial nerve. So we have a cistern here. We can see with the dissector, arachnoid. So we published in 2006 this anatomy of the oculomotor cistern. In relation with the clinoid segment, this is the clinoid segment below the anterior clinoid process. So in order to see the clinoid segment, we have to remove the anterior clinoid process. But it is better to understand this anatomy in the lateral view. So we can see here, this is the pituitary stalk, the diaphragm, the supraclinoid, a carotid artery, ophthalmic artery, optic nerve. And this is, we can see the shape of the anterior clinoid process. So this is the distal dural ring. This is the proximal dural ring that also it is called the carotid oculomotor membrane, because below this membrane is the third cranial nerve, and this is the clinoid segment of the carotid artery. This is the optic strut, and here we have some blood in relation with the cavernous sinus. Another important thing, we have a very thin membrane, the carotid collar, in the lateral portion of the clinoid segment of the carotid artery. So, distal dural ring, carotid collar, proximal dural ring, optic strut. In relation with the lateral wall of the cavernous sinus, we have two dural layers, an outer that is thick, a meningeal dura, and an inner layer, a periostic dura. And exists a cleavage plane between both dural layers, and so we can see both layers, the outer layer and the inner layer with the cranial nerves, third, fourth, B1, B2, B3. So in this view, in the right side, we can see optic nerve, carotid artery, third cranial nerve, fourth cranial nerve, anterior clinoid process. So we cannot see the nerve in the lateral wall because the outer layer is very thick. But we can remove, and we can see the inner layer. This is very thin layer, third, fourth, B1, B2, and so on. So we can see, but if we want to have a picture of the cavernous sinus, we have to remove this inner layer, and we can see very well the nerve, third, fourth, and trigeminal nerve. Okay, but it is interesting to know that we can separate easy the outer and the inner layer in this way, and this is the peeling of the lateral wall of the cavernous sinus or peeling of the middle fossa. But this is well done, and this is not well done, because when we do in a good fashion, we have to preserve the inner layer in relation with the nerve. So we see the nerves, the third, the fourth, B1, blah, 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 so on, with the inner layer. But here, in a not well done fashion, we see directly the third, the fourth, and B1. And we can see also the internal carotid artery in the cavernous sinus. And another important thing here, this is the orbitomeningeal band. We have to cut the orbitomeningeal band in order to can separate the outer and inner layer and to expose this inner layer in the lateral wall of the cavernous sinus. And we have some studies about that. The posterior wall, it is part of the dura that covers the clivus. It is between the dorsum of the sella and the ostium of the Meckel cave, and it has a very close relationship with the sixth cranial nerve. So this is bone, and we can see the posterior view, the posterior wall of the cavernous sinus. This is the fifth cranial nerve, fourth, third, and this is the sixth cranial nerve, and the hole where the sixth cranial nerve perforate the dura in the clivus. But it is important to understand and to know that this is not the Dorello canal. Dorello canal is here inside the posterior wall of the cavernous sinus. So in this dissection, we cut the dura in the midline. So this is sixth cranial nerve. This is the hole where perforate the dura in the clivus. But this is the Dorello canal. This is the Gruber ligament, and the sixth cranial nerve go, and then go from in this part. It has a vertical direction, but here change the direction and go from posterior to anterior. So this is a hole in the dura, and this is the Dorellos canal. And we can see the all dissection with this is the basilar plexus. The medial wall of the cavernous sinus is the only wall which cannot be observed in the skull base. We have to remove the pituitary gland or go from lateral to medially to see the medial wall. It's the only wall with just one dural layer. The other, the roof, the posterior and the lateral has two layers and also has anatomical two segments, the sellar part and the phenoidal part. We published in 2004 this paper with Dr. Roton Laboratory about the medial wall. In that time, some authors denied the existence of the medial wall, a dural wall between the pituitary gland and the content of the cavernous sinus. So we will perform a dissection from laterally to medially in order to see the medial wall of the cavernous sinus. This is the medial wall of the cavernous sinus that has two portions, a pituitary portion and an sphenoidal portion. The sphenoidal portion is related to the carotid sulcus. We cut the carotids in order to understand this. And this is the dissection, and this is a picture. So pituitary portion, we can see in this remove sinus. This is the medial wall, the pituitary portion, and also the sphenoidal portion, and we are separating the dura from the pituitary and the dura from the sphenoid bone or the cella. Exists an anterior wall of the cavernous sinus. For the endoscopic view, we think that yes, and it is ahead of the cavernous internal carotid artery. We published last year to try to define the limit of the anterior wall of the cavernous sinus. And in anterior view, the limits are the middle clinoid, the middle optic carotid recess, the lateral optic carotid recess, the maxillar strat, and the clival recess. That are the limit of the anterior wall of the cavernous sinus. Finally, the internal content of the cavernous sinus, we have mainly the cavernous carotid artery with basically two branches, the meningohypophyseal branch or trunk and the inferolateral trunk. The meningohypophyseal trunk has three branches, usually, sometimes one branch starts alone. This is the inferior hypophyseal artery that go just to the posterior portion of the pituitary gland, the tentorial artery, and the dorsal meningeal artery. We will see in this specimen, this is the inferolateral trunk in relation with the fifth cranial nerve. This is third, fourth, B1, B2, B3, and sixth cranial nerve, and the inferolateral trunk, and the meningohypophyseal trunk. We have to remove this part of the silicone in order to see. This is the meningohypophyseal trunk, and we can see the inferior hypophyseal artery, the tentorial artery that go to the tentorium, and also the dorsal meningeal artery in relation with the sixth cranial nerve in the clival portion. And we remove the carotids here, and we can see the inferolateral trunk, the meningohypophyseal trunk, the inferior hypophyseal artery, tentorial artery, and also dorsal meningeal artery. We have some phrase or philosophy that we try to share with our residents and with the young neurosurgery, and is from the laboratory to the operating room, and that is the real power of the anatomy. This is in 2004 when we performed the fellow with Professor Roton in the Brain Institute. So thank you very much for your attention.